Thanks, Mike. Full disclosure, the first thing that Mike asked me when he saw me today was, what are you doing presenting at an advanced MIS section? And I'm not really sure how to answer that, but thanks a lot for having me, Roger and Luis. It's a great course. I learned a lot. I work in a cancer center. I mostly take care of patients with active cancer. For us, minimally invasive surgical techniques have really been, a complete game changer and really revolutionized the outcomes and the types of things that we do for our patients. All these patients are on chemotherapy, radiation, and it's really imperative to avoid any wound complications and to get them back to that type of therapy as quickly as possible. Minimizing the invasiveness of the approach has really made that difference, and we can really get them back to chemotherapy and radiation right away. We use MIS a lot, and so we've developed this algorithm that helps us determine exactly the type of surgery that we would want to do using minimally invasive techniques. And I'll try to show a case that illustrates each one of these steps. So the first one, 61-year-old woman, metastatic pancreatic cancer. She had prior radiation to C6 and C7, but progressed and fractured. And now she has intractable neck pain with a severe radiculopathy. She has a C7 metastasis that extends into the posterior elements as well, with a fracture and pretty significant epidural disease with spinal cord compression. So this is the type of patient that certainly needs to be decompressed and stabilized. She's mechanically unstable and has high-grade cord compression. And so if we apply this algorithm, she needs a decompression. And for her, we did percutaneous instrumental stabilization that was cervicothoracic, and a mini open decompression. The whole concept of cervical pedicle screws is kind of new to me, but since we actually have access to a percutaneous system, I've been tempted to try to experiment with it a little bit, and so far it's working out quite well. So the instrumentation was percutaneous with minimal tissue dissection and one-level laminectomy and facetectomy for the decompression. And she went right on to radiotherapy. Another case, 43-year-old woman with thymoma. She has interscapular pain, and she presents with an axial image that shows, some epidural disease. She's neurologically asymptomatic, but after discussing with the radiation oncologist, the feeling was that she would benefit from some decompression in order to optimize the radiation dose. So another patient who would benefit from decompression doesn't necessarily need stabilization. She's not mechanically unstable, so same idea, decompression needed. We used a tubular retractor to do a laminotomy with resection of epidural tumor. You see that in the postoperative CT myelogram that we use for radiation planning. The epidural tumor is gone and spinal cord is decompressed. And she was able to get an ablative dose of radiosurgery very quickly. 56-year-old woman, non-small cell lung carcinoma. She was actually in the process of undergoing radiotherapy to the L3 lesion and developed very severe pain and fracture progression at L3. And so she's unable to stand, unable to go through the rest of the radiation, neurologically intact. Tumor-wise, we can continue with radiation or treat her with radiosurgery, but she has this symptom of mechanical radiculopathy. And before this used to be tube up, tube below, open surgery with a facetectomy. Now it's also percutaneous stabilization with a unilateral facetectomy through a tube. And again, for somebody who is in the midst of radiation, this would probably be somebody who would require plastic surgery closure, because we'd know that she would be at high risk of falling apart in the middle of radiation. But for her, it really wasn't a problem. The small incisions, the tubular decompression and facetectomy, and she went right back to radiation right after the operation. Slightly different flavor of tumor. This is a plasmacytoma, 67-year-old woman. She has mechanical instability, unable to lie flat due to the fracture, and she has epidural extension. So the tumor itself can be treated with radiation. That's not our problem. But she is unstable. She has symptoms of mechanical instability, so requires stabilization. For somebody with cord compression, we don't necessarily want to kyphoplasty her because we worry about pushing the fragments back into the spinal canal and making the cord compression worse. So she's a perfect candidate for percutaneous instrumental stabilization, and again, went right on to radiotherapy. Similar case, renal cell carcinoma, the thoracolumbar junction. This is actually my bread and butter. The thoracolumbar junction is very symptomatic when it comes to lytic destruction of the vertebral body and pedicle. The tumor itself, not very compressive, can be treated with radiosurgery, but the patient is unstable. And this is probably about 50% of my practice now, this type of construct, where we use fenestrated screws for short segment fixation, and also kyphoplasty at the level of the tumor in order to provide additional anterior column support. And then finally, the last part of the puzzle here is somebody who is a reasonable kyphoplasty candidate. This is somebody with a lumbar compression fracture, turned out to be renal cell carcinoma that can be treated with radiosurgery, but the patient goes on to kyphoplasty, full resolution of mechanical pain, and also treated with radiation without needing any type of major surgical excision of the tumor. I have to mention fenestrated screws for these patients because, they've really been a boon and changed how we do things. There used to be long constructs. The mantra was always 2 levels above and below any type of stabilization around the tumor. And we've really abandoned that, at least in my practice, because we really rely on short segment fixation now. A lot of people have been asking me, why do you bother with cement augmentation? I think it's a transition. I think a lot of people actually really do have good experience with short segment stabilization of metastatic fractures without requiring cement. But since we're moving from really long constructs to shorter ones, we like to use belt and suspenders, so cement makes us feel better. But the technique is really straightforward. Once you have the screws placed, they have fenestrations, and you can inject the cement in concert with a kyphoplasty. That's really the only part of the surgery where we now use x-rays. Everything else is navigated. And this actually brings to the navigation. There's a lot of discussion about the benefits of navigation. In tumor surgery, I think, again, there are really sort of certain peculiar things to tumor surgery that make navigation critical and very helpful. For primary tumors, knowing where the tumor margin is and being able to stay outside of the tumor. For metastatic tumors, confirming the decompression is adequate. Certainly stabilization, and now there's a growing field for ablation as well, and knowing where to put the ablation probe, whether it's radiofrequency ablation or laser ablation, is critical, and that's navigation has been very helpful for that as well. And same for brachytherapy. There are some protocols where we place brachytherapy seeds into the vertebral bodies for re-irradiation cases. And once again, knowing exactly where the brachytherapy seeds end up is very helpful, and we use navigation for that. I'm a student of Rogers, so I'm also a big believer in total navigation. And I think again, for the certain components of tumor surgery where it's very helpful. Skin incision is common to all the surgery. And a lot of people ask about skiving in the thoracic spine and the lumbar spine. My answer to that is actually I place a tubular retractor prior to placement of the pilot hole, and it just gives me additional information about where the bone is, some visual confirmation, and I don't really have to, I really minimize, how much muscle and pressure I apply when I'm making the pilot hole and placing the screw. And so we place the tubular retractor, we navigate that, and then we can navigate the drill guide. This is basically the setup. This is the tubular retractor right here, and the drill guide that's fully integrated into the navigation system being used for the pilot hole. And once I can confirm the pilot hole, we can measure the screw, know exactly the width and the length of the screw that we want to place, and navigate that as well. Similar system that was mentioned by Roger, which is a unitized system for the screw placement through the pilot hole. And finally, kyphoplasty. So, you saw a lot of cement pictures in my talk. And once again, really guiding the cement and where we're going to be placing the balloon is critical sometimes. Sometimes we want it to be in the tumor. Sometimes we actually want it to be in the bone that's reasonably normal in order to reinforce that instead of the tumor. And so navigation helps us place that. And we use the integrated gem sheeting needle into the navigation system, and then the placement of the retractor for the decompression. A lot of the time, we don't have the luxury of having intact posterior elements and lamina, and so when you put the initial dilator, sometimes we have to be careful not to go into the spinal canal when there's lytic tumor in the lamina. So once again, having navigation, knowing exactly where we are with these dilators, is very helpful. So in conclusion, MIS is really very helpful in patients with metastatic tumors, allows minimal interruption in systemic therapy and radiation, and very quick return to those modalities that actually change their survival for these patients. We use a lot of fenestrated screws, and navigation helps with all of it. Thank you.
All right. Well, Ilya, that was an amazing presentation. Now, we practice right across the street, but we don't really interact that frequently, and we don't really show cases to it. So I haven't seen this. This is really great work. I think this makes a huge difference. Any questions, comments? Yeah.
Say a few words about the protocol for the renal cell case that you showed for embolizing, how and when?
Well, so these were all patients who didn't really have any resection of their tumor. All the tumors were treated with radiosurgery, so there's no reason to embolize them. If we do open surgery, when we decompress, then all renal cell patients get preoperative embolization, absolutely.
Like before?
1 to 2 days is usually what we do. We try to do it within 48 hours.
So a question to your radiation protocol. So if you do a case like this, you said you started radiation or continued radiation right thereafter. What do you mean by right thereafter? Because we do the same, we do it the same way, and even with PERC screws, we feel that maybe 5 days or a week of non-radiating would be a good idea for wound healing. You don't care anymore, or?
I think 5 days is about what usually ends up happening anyway, and that's probably my minimum, unless we're really pushed to do something sooner. We've gotten away with these small incisions with a lot of stuff. There's a drug called Avastin, for example, where we have to wait 4 weeks usually to operate on it. But I've had a few patients who needed surgery, and again, for PERC stabilization, I was able to do an Avastin, and the incision stayed closed. But I think just in terms of reality of pain and postoperative mobilization, when can we get them? And it also depends on the radiation. There's conventional radiation, there's radiosurgery. Radiosurgery can be tailored to spare the incision, so it's a lot easier to say, let's just keep pressing on. Conventional, usually 5 to 7 days, I think, is.
Excuse me? What kind of percutaneous cervical screws did you use?
Yeah, so it's, I didn't have a disclosure slide, but there's and I've consulted for this company, it's called SpineWave. They have a new system that has extended tabs for the cervical system. So I've done a few cases. It's a work in progress, but I think, again, for these patients, it's pretty helpful, because especially if we're talking about cervicothoracic, that tends to be the more symptomatic area for the approaches, for the open approaches. And also, I have a lot of colleagues who even up front use plastic surgeons, because that tends to be the area that falls apart the most. So I think if we can start applying percutaneous techniques to that stabilization, it would be really meaningful.
We have Professor Wipplinger, real quick.
Hi, Christoph Wipplinger from Innsbruck. I wanted to ask, do you use any kind of system to determine scoring system to determine to what extent you resect the tumor, or if you just do palliative surgery like Tokuhashi or Tomita?
So, the system that we use for decision making is called NOMS. For every one of those patients, I had the NOMS slide. I didn't really spend much time on it because,
Okay.
I was trying to talk more about the techniques. But that's the decision framework that we use. All these surgeries are palliative. I mean, these are cancer patients, so you're really palliating their spinal problem. You're not curing them of cancer.
Yeah, Ufuk, yeah.
Yeah, two things about, maybe three things. One is using the kyphoplasty or vertebroplasty. Does it make any difference? Because when you inflate the balloon inside the tumor mass, so you're pushing some of the tumor cells to the posterior side of the vertebral body. I have seen this kind of cases in my practice, and they are ending up with the spinal canal invasion. This is one thing. The second thing is about the same day minimally invasive surgery and radiotherapy. This is happening in Dutch now. The Utrecht guys are doing it. They started a year ago. So it's you can do that in the same day. The third thing, we are calling that, let's say, renal cell RCC. But we know that all RCCs are not the same. So what's your preference of doing a minimally invasive approach to the RCC? Do you do it for synchronized tumors? I mean, if you get a patient have the renal cell removal, let's say 3 months ago, and you have the vertebral problem 3 months later, you do it less invasive things. Or if you have a patient with kidney removed, let's say 3 years ago, and now you have a metastasis after 3-4 years later.
I'm going to work my way back because I'm not sure I'll remember all three questions. But For renal cell, radiosurgery has been extremely effective. We have data showing 95% control. So it doesn't particularly matter whether it's somebody who has concurrent metastasis or metastasis that presents later. You're right, obviously, there's variability, but we don't really see that much variability in terms of the tumor control. So it all comes down to the indication for the surgery, whether it's the type of surgery that we do, which is separation surgery, decompressing the spinal cord, leaving most of the vertebral body tumor in place for postoperative radiation. The extent of tumor resection doesn't matter as long as we can get them to effective SBRT. So it really comes down to the question of mechanical stability and adequate spinal cord decompression, not the extent of tumor resection. J.J. Verlan in Utrecht is doing this, the protocol. I think he completed phase 2 already and is moving on to a bigger study. It's a great study, fully supportive. We haven't quite started doing just, for mechanical reasons, logistical reasons, that same concept of trying to do it within 24 hours, but I think it's a great concept. As far as kyphoplasty before or after radiosurgery, we actually published in this because there were a couple of case reports of tumors getting worse after kyphoplasty. I think a lot of it is about technique and the timing. If you look carefully, most of those case reports were, you couldn't tell how long the interval was between kyphoplasty and radiosurgery. It looked like the tumors just really grew more so than anything else. I tend to work with an interventional radiologist who does a ton of these kyphoplasties, so we do a lot of these procedures together. We use kyphoplasty mostly rather than vertebroplasty because the feeling is, you create a cavity and you can get a better cement fill. And so we published kyphoplasty followed by SBRT, where, we really saw no concerns about tumor control when it comes to that.
I think Mike has a final.
Yeah, Ilya, that's fantastic. Two quick questions. The first is you've definitely shortened the construct length now with one above, one below, and nothing really at the index level except for some cement. I think in the thoracic, there's a lot of stability with the ribs and everything works out well there. But sometimes in the lumbar, mid-lumbar, TL junction, as you were mentioning there, sometimes the failures, if you do get some collapse at the index level, and kind of the windshield wiper action or the lateral collapse, have you seen much of that sort of failure at all?
No, I mean, that's why I put up that case, the thoracolumbar one, because that really is the most symptomatic and the most frequent one that I stabilize. Short segment works fine. The two places where I've had, screw fractures there, and, this is out of hundreds probably, is where we also did a decompression and a full facetectomy. So who knows? It hasn't really forced me to change practice for that yet. But it's very rare that we see failures for this. Maybe cement helps. I don't know. We tend to use it just because we feel safer with it. Right. But I know a whole bunch of people who do without cement and it works just fine.
And the second question, which is, what is the extent of decompression that you're willing to do through a small port? Will you go circumferential? Will you take down both pedicles? Are you worried about hemostasis in that setting? How big will you go through a small corridor?
I don't really have a great answer for that because that part for me is really, I'm trying to get more experience with it. I've done a few cases and I try to, for the beginning, try to pick the safer cases where I'm not too worried about bleeding, tumor being mostly lateral. If I'm really worried and I know that I need, very good thorough decompression, I still tend to do it open, but, I think it's just a matter of getting more experience with that.
Great. Thanks.
No, we used to be able, when these patients come in Friday afternoon, and they have, like 75 years old, and you can always talk yourself out of an operation because you say, well, the life expectancy, they're too sick. But now you're telling us we have to operate on all these patients because the surgery is so minimally invasive that there's no reason not to do it anymore.
I think minimally invasive has really expanded it. Yeah, I mean, there are different indications again, but I think the systemic stress, and it's one of the things I really would like to figure out whether the actual systemic stress is lower for these patients, and we don't really have great data for that. We have some fledgling papers in spine and other minimally invasive techniques showing that. But I think so. I mean, I think these are pretty straightforward ways to improve quality of life and preserve neurofunction. So,
have you written this up, these cases?
Most of them, yeah.
Yeah, good. All right, great.
I'll write some more.
Yeah, please. All right, thanks. That was great. Well.